So I'm going to talk about the pediatric airway, and I struggled a little bit to find where to pitch this, so I hope I don't disappoint people. So what I'm going to go through is a bit of anatomy and physiology, go through some of the clinical presentations. As an adult anaesthetist, you might be called down to attend in ED, some of the pathology behind those presentations. Just talk about stridor a little bit, because that's one of the most common reasons to be called in to have a look at them. Very briefly talk about airway management, mainly what we do differently to adult practice, and then just touch upon difficult airway. I might not go into details of the difficult airway. I can go into as much detail as you would like to. So obviously no talk about the pediatric airway is complete without a picture like this, mentioning all the differences between an adult and a child. As you can see, the children have a very large head with a large occiput, which means that if they lie down flat on a bed or trolley, they're likely to flex their necks and cause obstruction. Little ones, infants really, are obligate nasal breathers, and they don't tolerate obstruction very well. So if they come into ED with a little bit of upper respiratory tract infections, bit of secretions can cause significant airway obstruction in them. They have a relatively small mouth and a large tongue, which flops over very easily once we send them off to sleep, and causes airway obstruction again. It also makes it really difficult to get a view of the vocal cords, or can make it difficult. The epiglottis, going down further, so in adults, the axis of the epiglottis is parallel to the trachea, whereas in kids, it's angled away from it. And the epiglottis itself is quite large and overhangs the vocal cords, again making laryngoscopy a bit challenging. The larynx itself is more cephalate and more anterior compared to the adults. So it's opposite to C2, C3 in kids, whereas it's C5, 6 in adults. The trachea itself is really compressible in children, so a bit of hyperextension can actually cause the trachea to completely get compressed and cause airway obstruction. As it's mentioned there, the children rely mainly on their diaphragm to breathe. So anything that limits the movement of the diaphragm, like gastric distension, can cause obstruction again to their breathing, make it really hard for them. Coming to physiology, kids have a really high basal metabolic rate. It's about 5 to 8 ml per kilo, requiring much more oxygen than adults. So it's about double the oxygen consumption. So in kids, it's about 6 ml per kilo per hour, whereas in adults, it's just 3. So they have much lesser reserve than adults and desaturate much quicker. They have a relatively fixed tidal volume, and their minute ventilation is almost directly proportional to their respiratory rate. They have very compliant chest walls and not so compliant lungs, which means that their functional residual capacity is low, causing atelectasis and desaturation pretty quickly. The muscle fibers that they used to breathe with are type 1 muscle fibers. They tire easily, so if they start developing respiratory distress, then they progress pretty quickly to not being able to manage by themselves. If they do drop their saturations, unlike adults, the response to hypoxia is bradycardia, whereas in adults you get tachycardia. They become bradycardic pretty soon. And the effect of edema, you all know that the diameter of the kid's airway is really small, and anything that reduces it further severely affects airflow. So some of the clinical presentations that you might be called to support the airway and the breathing in ED, they might be either respiratory in presentation, or it might be non-respiratory conditions that are presenting for airway and breathing support. So as you can see, breathlessness, cough, stridor, which I will deal with in a little bit more detail, and chest pain. The non-respiratory, well, they can come in with poor feeding, and that can mean anything in kids. It could be respiratory problems, cardiac problems, or further lower down. abdominal pain, causing, particularly if they've got distension or any other abdominal pathology, can affect their breathing. Similarly, the other ones mentioned can all present with respiratory complications. So looking at some of the pathology that can cause these problems, upper airway obstruction usually is due to infections or foreign bodies, which is relatively common in children. Again, infections in lower airway obstructions, asthma as well, disorders of the lung itself, disorders around the lungs. So pneumothorax is not that uncommon in children, and because they have a very compliant chest wall, they compensate really well, and the signs of pneumothorax that you would have picked up in an adult sometimes is masked till the later stages. Disorders of respiratory muscles, the diaphragm, like I mentioned, abdominal distension is a major issue when you're trying to backmask ventilate little ones. You blow up their stomach, and which makes it even more difficult to backmask ventilate them. So passing a suction tube down into the stomach and deflating the stomach is a good way of making the situation better. So coming to stridor, if you have a little baby like a neonate coming in with stridor, the most common cause for stridor is in that age group is laryngomalacia. They're usually okay, and they usually grow out of it by 18 to 24 months, but some of them can be more severe, obviously, and lead to feeding problems and failure to thrive. Infections, any of those mentioned over there can present with stridor, and be a tricky airway as well. Foreign body, again, as I mentioned, is not uncommon in children. Trauma, relatively rare compared to adults. Laryngospasm is fairly common. Obviously, stridor is only present in partial laryngospasm. Complete laryngospasm, you won't have any noise at all. Vocal cord dysfunction, again, it can present in little babies as congenital vocal cord palsies or later on in life. So whatever be the presentation or the pathology, the indications for intubation would be almost the same as in adults. So failure to oxygenate or remove CO2, increased work of breathing, neuromuscular weakness, CNS, and CVS failure. So if there's anything that you can do before intubating to make the situation better, other than airway maneuvers, using drugs. Can anybody think of most favorite drugs in these situations? Yeah. Adrenaline. We all like adrenaline, and we give loads of it. So about 0.3 to 0.5 milligrams per kilo, diluted in about 5 mils of saline, and nebulized through a nebulizer. It does make a huge difference in these kids, and it's often we reach for it very often in ED or post ENT surgery. Anything else? You've seen my slides. So, yeah, dexamethasone in a dose of about 0.25 to 0.3 milligrams per kilo will reduce airway edema. Again, it's given routinely in all airway procedures in theatre, so that's a good one to give. And then atropine, I always drop atropine just to ward off evil spirits. So airway management. So simple things first. Positioning, as we mentioned earlier, can be really important because, as you can see, a little child lying flat like that, and that's what happens. And just placing a roll under the shoulders just improves the airway significantly. The other things we mentioned was suctioning. Just need to be a bit careful with kids because they have a very high vagal tone. So there is a likelihood of causing bradycardia with suctioning. but it's still something worth doing, especially if they're full of secretions. The head tilt, chin lift, jaw thrust maneuver, which all of us do. Again, just to keep in mind that the chin lift, you need to restrict your fingers to the bony elements of the chin because you've got really squishy soft tissue and you can cause obstruction just by doing chin lift itself. Adjuncts, airway adjuncts, consider using them if you need to. So I'll come to that in the next slide in a bit. If required, we might need to support the breathing, so bag mask ventilation. All of us use T pieces if they're less than 10 kilos or between 10 to 15 kilos. I tend to use them even for slightly older children because it gives a really good idea of the compliance. Obviously not big children. And if required, obviously intubation. So what could be done while preparing to intubate or when you've rung one of us to come in the meantime? Get all the stuff ready. So suction. So sizes of suction tubes, it's roughly twice an uncuffed ET tube size, what you would have predicted for the child. Very useful, as I said, for deflating the stomach and other sucking out secretions. Oxygen delivery systems, so nasal cannulae, face masks, which are appropriate to the age, and appropriate bags, again, depending on the age of the child. So the airway adjuncts I mentioned, the oropharyngeal airway, don't hesitate to use one if you need to. They're made to make they are there to make our life easier, and it's not an admission of incompetence if you have to use an oropharyngeal airway to get a good patent airway. Stillets and bougies, again, quite very useful, but you have to bear in mind that the pediatric airway is really, really delicate. Pushing it further in than it needs to go can cause trauma, so you need to be very careful. Drugs. So apart from the drugs that we talked about earlier, the usual anesthetic drugs like induction agents, relaxants, and the rest, and monitoring. So you often get asked which blade to use. So the blades that we have here regularly on our airway trolley are the Miller and the Macintosh and the Cardiff. So which blade do you use? In a neonate, straight blades are preferred because they can be used to pick the epiglottis up. Slightly older children, the Macintosh will be fine. Cardiff Pro is in between the Miller and the Macintosh. So it's straight to the very end and then it curves. So at the end of the day, the idea is to get the ET tube into the trachea. So you use the blade that you're most comfortable with. But as a recommendation or suggestion, Miller blades in neonates and probably Cardiff or Macintosh in older kids. The other question is, what sort of tube do you use, cuffed tube or an uncuffed one? This paper, now quite old, it was published in 2009, sort of a landmark paper on cuffed tubes in children, which basically said that cuffed tube in small children provides reliable sealing of the airway in cuff pressures less than 20 centimeters of water, which is considered safe in kids. It reduces the number of tracheal tube changes, which you would otherwise do with uncuffed tubes, and it doesn't increase the incidence of post-extubation stridor. More recently, there's been another paper in the Journal of Anesthesia where they've looked at a couple of RCTs and 2 prospective cohort studies, including a huge number of patients, so over 3,700 patients, and they come up with the same conclusions, that it does not increase the incidence of post-extubation stridor, which was the main concern with using cuffed tubes. So cuffed tubes definitely preferred where there is a risk of aspiration, low lung compliance conditions, and where you need precise control of ventilation and carbon dioxide, like neuroprotection. The microcuff ET tubes that we have have a more anatomical fit with lower sealing pressures. The cuff position is more distal compared to the standard cuffed pediatric endotracheal tubes, and I think John's got a picture of them to show you later. ET tubes, John's going to talk about sizing ET tubes as well for older kids, but this is for just the littler ones. The one on top which says neonates, it's for the ex-prem neonates, is roughly about a tenth of their gestational age, and the rest of the sizes are, as you can see it. So just going to touch about difficult airway. Thankfully, it's quite rare in children. As you can see, about 0.08% in healthy children and 0.42, which looks like a big number, but it's including all the syndromic children in it. And that was from the Anesthesiology Journal. And a more recent one, the one in pediatric anesthesia is from 2004, which says it's 0.095% if in all children less than 16 years. And if you look at the ones less than 1 year, in which it's more common, it's 0.24%. There's been another paper in 2016, I think, in pediatric anesthesia, which says the incidence is 0.3 or 0.35 in the under ones. Difficult ventilation is again quite rare, as reported in this paper. It says it's difficult but never impossible. The good thing with kids is that they're either if they are difficult, they're either difficult intubation or difficult ventilation. Very, very rarely they're difficult both. Difficult ventilation, it is greater in less experienced hands. It could be anatomical because of dysmorphic features, so mid-face hypoplasia or retrognathism. Or it could be functional because of laryngospasm, unable to get the air into the lungs due to light anesthesia or gastric distension or bronchospasm. Some of the indicators which might suggest that it's going to be difficult is snoring, daytime somnolence, which might indicate that they've got sleep disordered breathing or OSA. Dyspnea. So episodes of the child going blue when at home. It might be either respiratory or cardiac in origin. Stridor, hoarseness, and if they've got a preferred position to sit or lie in. And some of the features that you can come across in physical examination, quite obvious in dysmorphic faces, and the rest of the signs as mentioned. Equipment, what we have here for difficult intubation, we've got glide scopes, we've got the air track. I haven't used the air track myself, but I think it is useful to have them around. We've got fiber optic scopes. The nase endoscopes, we don't keep them. Usually the pediatric ENT surgeons come with one if you ever ask them to come down. We've got bronchoscopes. So the nase endoscopes, they do take smaller tubes. You can load smaller tubes onto them. It might be limited by the length of the tube that's required because it might limit the movement of the scope for the surgeons. The smallest bronchoscope, so the 2.8 millimeter bronchoscope can take a 3.5 millimeter ET tube, which would be one that a full-term unit should be able to take. So like I mentioned before, disadvantages in children with difficult airway. We don't have the luxury of doing an awake fiber optic. Very, very unlikely. Sometimes possible in older children. Advantages, they are easier than adults to keep asleep and spontaneously breathing and adequately oxygenated. So in difficult airway management, what I would do is anesthetize in a pediatric theatre, not in ED, definitely not in ED. And have an airway surgeon present. So before I anesthetize, I probably want my ENT airway surgeon to be present if I'm anticipating difficulties. I always do an inhalational induction, keep them spontaneously breathing. Make sure you have IV access before you do laryngoscopy and avoid your muscular blockers. You want them breathing spontaneously. So the Laryngoscope or the Hopkins rod can be very useful in conditions where none of our usual methods work. So the surgeons usually have them, and if ever you need to use a Hopkins rod, as I've been told before by John Emery, make sure that it's loaded with an ET tube in case you've got to intubate, because sometimes you might have just one chance at getting it in. So I have put these slides up. They are really, really busy, and I don't know if you want me to go through all of it. I have put a little summary up, and I think John is also going to talk about a little bit about difficult intubation. I've just put a little summary which says what you should do or shouldn't do. So maintain oxygenation. I don't know why it says ventilation, sorry. So limit attempts at laryngoscopy to 4. Obviously, the more times you try, the more morbidity. Because their tissues are really, really delicate. Trauma and high failure rates with line techniques. If you're in a can't ventilate, can't intubate situation, which I hope none of us are in, try a 2% technique to oxygenate. LMAs are really, really useful to try as rescue methods. And if all else fails, proceed to front of neck access, which John's going to talk about, and can be really difficult. Right?